My name is Dr. Tyler Tolbert,
And I'm Dr. Soren Poppy,
and you're listening to the Fix Podcast.
your source for all things implant dentistry.
And I remember Dr. Logan Locke, he's one of the primary doctors there, and he teaches 3 on 6, and it's brilliant clinician, really, really fantastic. And, he had this one patient, he mentioned, I think it was like 3 or 4 times, like throughout the course. He's like, yep, that's her, And you could tell he's like present in his mind. He was like getting texts about it, and he's like, I mean, he's one of the best like FP1 people like in the country for sure. And, surgical stuff's going to happen all the time, but it's just how you deal with people. And that's, it's something that you can always work on, and it will always there's just a few things that are going to make your life easier than just learning how to deal with, sometimes difficult people, for sure. So I think it definitely belongs in the conversation about how to survive in full arch.
Yeah, 100%. Yeah, 100% agreed. And the thing is, like, so just like reviewing kind of what we talked about, like fitness, personal development, like these things are hard to track, right? It's harder to learn because it's harder for us to track. We're used to like in dental school, you got learning class 2, learning class 3, learning class 4. It's easy to track your progression, but it's really hard it's intangible, right? How do you track your personal? And again, it's just like you said, I think it's just constant exposure to it, you're constantly thinking about it, getting exposed to it. So that's in the forefront of your mind too. But yeah, it's talking about that is, I think moving into the last point that I'm going to discuss, like what are full arch dentists missing in their toolkit or maybe can strengthen is just, I think a thing that I see a lot, especially with younger clinicians, but not just younger clinicians, it's any kind of clinician, right? Is just thinking more like a doctor and not just a technician, right? This is something that really picked up, just from all my time with hanging out with the OMFS guys at UF and my training with the Air Force and those attendings as well. Is just like, man, like you really have to. It is, you are a doctor, right? Do you know what I mean?
Yeah.
So we have to treatment plan and critically think like one, and especially when it comes to treatment planning, right? Like and this will kind of delve into what we're going to talk about later, but man, if you only have, if you only have a hammer, everything kind of looks like a nail, right? And when it comes to like FP3, that's the only skill, and we've been there too, right? Like I only just started doing FP1s, and I didn't want any kind of FP1 case that came across my lap that I was like, yep, that's an FP1. I'm not doing that. I refer out,
Yeah, that's not my
but it's about at least learning enough to know that, hey, this is a case that can be done a different way. Instead of like, yep, everyone FP3, FP3,
You bet.
and kind of like probably the most common kind of questions that you get from mentees is like, hey, how do I manage this patient? Patient has this health history. Like, what do I do? And I can already tell, like, there's the docs that kind of just ask the question, right? Like, hey, like HbA1c is 8.2. Like, what do I do? It's like, okay, like, what about everything else, right? Versus like sometimes I'll get docs that I know that they've maybe had some similar kind of training, like thinking more comprehensively, thinking more like a doctor is like, hey, like it doesn't take that long. We had to present all our patients like this to 62-year-old, African-American male, presents with past medical history of hypertension, type 2 diabetes, asthma, these kind of things. HbA1c is 8.2 is checked within the last 2 months. Patient does not bring their, very quick, it's a very quick, straight to the point patient presentation, on the past medical history, medications, allergies, social history, family history. It doesn't take long. And that way I get, it's just I call it the elevator pitch with my docs. Like, hey, give me the elevator pitch, in a voice note so that I can properly help you, answer this question, right? Because little things can affect it for sure. So I think learning those things, not forgetting those things, is really important. And, I'm going to use this opportunity to get on my soapbox here for, as far as additional training, right? Like, in residency, we all had to get ACLS certified because we also had the opportunity to get IV monitor sedation, and so I think that's it's a very good thing to get. If you're doing this kind of procedure day in day out. Another stressful call that probably you've gotten a lot of times is, hey, like my patient just high, like very like his blood pressure is super low, like they're sweating, like, what do I do? You know what I mean? And it's
Yeah.
like, all right, let's slow down. Let's think back to, the most common things that can happen, syncope, blah, blah, blah. Like, hey, did you get fluids? How much fluids have they gotten? All these kind of things. And what kind of can give you a lot more confidence in that is taking something like ACLS, because they run through a lot of these medical emergencies, especially the more serious ones. And the point of it is not to learn how to deal with it, right? But it's to just increase the chance of your patient surviving until EMS arrives, right? And there's a lot that can happen between that time, be it 10 minutes, be it 20 minutes, that you can do to kind of help the patient, literally support their life until more advanced care can be given, right? And it's the same thing when the EMS arrives, that they get to a hospital, you learn, and it's, say they're not a level 1 stroke center and that's what they need. They need to be doing these steps to keep support their life longer so that they can get to the next level of care. And so I think as someone doing full arch routinely, getting ACLS training, is a must, and it'll give you a lot more confidence too. Confidence in yourself. Once the team will be way more confident in you, because who are they looking to when something happens, right? You.
Right.
You don't
Yeah,
know.
the buck is stopping with you. Exactly.
Then
Yeah.
they're freaking out, So it's a great thing to have in your tool belt, and it just helps you think through those kind of situations more. And to be honest, that's one of the things that I haven't been able to do is so in the military we'd have monthly, just our oral surgeon would drop a dummy anywhere in the clinic, and then it'd be like a mock code blue, and to kind of run those situations. Obviously, it's kind of harder to do in a private practice, but I think doing it quarterly, or even biannually, quarterly, whatever. There are services I've heard that will come and do that for you and do that for the team. Obviously, you don't have to do it in front of patient care, but have a team training day
Yeah.
where that's something maybe. Hey, you just pop in and you have to deal with a situation like that. They know it's coming, but they don't know when.
Yeah.
It's a good way to kind of just keep everyone on their toes, and just also know that, hey, like, doc really cares about this, and he cares. It makes them care. They're like, this is important. Like, this is really important.
Yeah.
And it empowers them to feel more confident in those situations too.
Yeah. This reminds me of the Office episode where Dwight starts a fire in the office and he's like, we got more doors to the door handles. I mean, this,
Yeah,
it's hard to, you need to prepare for these situations. But no, seriously. Like I think that's extremely important. And if you want to do full arch and you want to do this all the time, guess what? You don't get ASA1 patients ever. That's just not the ball game. So I mean, everyone's got some risk. I mean, I see extremely hypertensive people on a daily basis that are just walking around having no clue. Uncontrolled diabetes, people who are waiting on a kidney transplant, heart transplant, whatever. So I mean, yeah, you do have to be familiar with these things. And even if you work with say an anesthesia team that goes through and pre-ops all your patients and make sure they're surgically optimized and they're going to be having IV access throughout the procedure, certainly that makes things a lot safer. But that doesn't abdicate the responsibility that you have as a doctor. And you have to remember, like, regardless of how you feel about your own role in taking care of people, everyone in the office thinks that you know how to do it. They think that if something happens, go get the doctor, and like you're going to be solving the problem. Like, remember, like, you are the person they're going to count on to do that.
Absolutely.
And that should make you feel a little anxious, and you can replace that anxiety with knowledge. So I totally agree. Like, you have to get ACLS training and do it frequently. I mean, I did it, years and years ago, and I recently redid it because, that stuff doesn't really stick with you because it doesn't happen every day, right? Like, hopefully these things never happen, but they
Right.
do. I think that's a great point. And, so much of this really just comes down to having the fundamentals just really, really down pat, right? Everything that we're talking about comes down to fundamentals. So
Yeah.
I think they're an important point. So I know you've been itching for it. I've been itching for it. It's time to talk about regenerative dentistry. So, so first of all, like, I want to talk about, what is regenerative dentistry in the first place? What does that really mean? What does it mean in the context of full arch? And how should we be thinking about it? When I first got into full arch, I kind of alluded to this earlier. When I was doing it, it was like regenerative just kind of got thrown out the window completely. Like, we're not here to graft, we're not here to socket preserve. Like, we're here to find bone, get implants in there, get torque, and then throw some teeth on and let the body do its thing, right? And it's been over time that I've learned, the value of regenerative dentistry. But how would you define that?
Yeah, that's a great question, a great point, because it's like, when I started too, and it's obviously trickled down from what you've learned as well and education sources, but most of the course you'll see, I mean, all four is touted as a graftless solution, right? And that sounds great, but I think, and we'll talk about this more in depth later, but I like to use something, a term called optimally invasive treatment planning, right? Doing what's necessary for the case, not more, not less, but not just doing the least amount for the sake of being conservative, right? But not just going completely overboard and finding that balance point. But grafting is a very general term, and grafting can involve autogenous, grafting or biomaterials. For me, like personally, I like the concept of minimizing, minimally grafting solutions for full arch, and minimizing the amount of biomaterials used. So like, for FP3 cases, patients that are indicated for FP3, usually you can save enough, autogenous bone just through your alveolectomy. I personally, it takes a little bit longer, but, mark my lines, and I use a rod, double action rod and drawer for the first part of my, 70% of the alveolectomy to try to get all that, as much bone as I can. And then I take the rest with a burr. And usually that's enough to not even, pack the sockets. Why not? You have it there. Right. And then on the soft
And I will mention too as well, it seems like it's a lot slower, but like if you really know how to use a double action rongeur, as long as it's not like super cortical bone, like it can actually really speed up the procedure dramatically. It doesn't make as much of a mess. You're not throwing water all over the place. Like a rongeurs can do like 80% of your alveolectomy, like pretty quickly.
Yeah, and I'll say, because I actually do. I don't have the benefit in Georgia of having GA for every case.
Yeah.
So 90% of my cases, I'd say even 90 up to 95% of my cases are done oral sedation. Like the patients don't really respond when you're using it. Yeah, so I'm like, here comes nail clippers, and like
That's what I say every time.
They really, some of them will start coughing and stuff when the water starts coming. From
your no, it's a lot, and you get gauze helicopters and all kinds of stuff. Like it's it's a ton, and it's a lot for patients, and they panic because they feel like they're being waterboarded. Like the less water you can squirt in their mouth, the better. And rongeurs are really powerful for that, and it's a source of autogenous grafting. We do that for every single case.
Yeah, 100%. And on the soft tissue side, right? Oh, well, let's finish up the hard tissue. So like, autogenous bone, 100%, is usually enough to fill up most of the sockets, and maybe even graft some buccal defects. Of course, if you have a buccal defect, some people say you can just lay the autogenous bone on there. I still like to put some sort of a collagen membrane, even for a within the contour defect. But either way you go, it's still minimizing the amount of biomaterials, right? And then two, if you save all that autogenous bone, say you didn't have that much reduction, and you still needed to graft, well, you still have some autogenous bone, but instead of opening up a 2 cc or 1 cc packet of allograft, now you only just maybe need to use 0.5. And then added with some PRF, it really increases that kind of, I know it's not true volume, but the graft itself will be stickier, easier to manipulate, blah, blah, blah. But it'll be able to maintain that blood clot space, right? Bigger. So it really minimizes the amount of actual biomaterial or allograft or xenograft that you have to use. Most of that mix is autogenous. So going towards that, towards the soft tissue side, right? Like, especially on the maxilla, like if you're blessed with a lot of, palatal thickness, that can actually be a problem with your prost, right? I know Dr. Clark Damon preaches this all the time. You start trimming the palatal tissue so you get, a little bit more space for your prosthetic, and you don't have to reduce some sort of bone. Why throw it away? Like, of course, if the patient has miles of bone, miles of soft tissue, it's not worth the extra time. But if they're thin tissue phenotype, maybe you save it for the lower, especially the lower anteriors, right? Save it for the lower, and it takes not that long to tack it on the inside of the flap, and you have a free CTG there, and takes 10, 15 extra minutes, but I think it's worth it down the line when you don't have to. It's always easier to graft at the time of surgery than it is after.
Yeah, I that is something I do routinely, in thinning the tissue as well as obviously trimming the tissue as well. Sometimes you have that wall of tissue, and you just, cut that right out, and then you thin everything out, try and, dig the depth of the 15, like all the way through, get a good, 10 millimeter slice and really thin that tissue. And you can absolutely throw that down. It could be a CTG. I also saw, it was Melanie Toe's presentation at Orca. She was actually, she showed one where I believe she did an FGG. So she, took a big, slice out of the palate and then basically made it into a poncho for like the lower abutment. So she like threaded the straight abutment right through that FGG from the palate and, suture it all together. And like, that couldn't be any easier, right? Like that's super, super easy. And you just did, simultaneously soft tissue grafting and, gave your lower implants a whole lot of insurance. So, it's all there. It's free and available especially if you're doing FP3, there's a fair amount of production. Like there's a lot of tissue to be had in most cases. So yeah, that's something I've started to do a lot more routinely. I think it's great.
Yeah. And it sets the patient up for success. It's definitely worth it. Yeah. So that kind of like transitions to like the concept of being optimally invasive, right? Like you hear minimally invasive all the time, and minimally invasive is I think it's a relative term, right? And so is optimally invasive, but we'll talk about the difference. Like I think minimally invasive, like people get too stuck on like what is the less is better, right? Like an operative, right? Let's just start like with operative. Like E1 lesion, like all right, if you're in dental school, remineralize.
Yeah.
There's no other discussion about like, oh, what's the caries risk? Like what's their patient's willingness to change? What's their diet like? What like all these kind of things. Like what is optimally invasive for the patient? The patient that maybe has 1 or 2 D1 lesions, like sure, they're willing to clean up their act. They're like, oh crap, like I don't want that anymore. Like I'll do what do I need to do, doc? Like yeah, for that patient, the optimally invasive thing to do would be to try to remineralize. Versus you got the patient's 50s, 60s, like, yeah, doc, I'm gonna be honest with you, I ain't gonna stop smoking. I'm not gonna stop drinking, Mountain Dew, blah, 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 all these things you're talking about. I'm just not gonna do it. For that patient, the optimally invasive thing is to do the filling, right? And
I
that's
thought you were gonna say full arch, but that's fine.
well, yeah. So let's
Sometimes.
let's apply it to full arch. Like if it's just assume the patient is indicated for FP3 and it looks like a standard
Yeah.
all-4 arch. You go in there, got let's just say standard for all-4, but you couldn't get torque on the posteriors. What are you doing? What you go for the nose, still no torque. What are you doing?
Yeah, I mean that's a good question, right? And I think that what we're kind of alluding to is we talk about this on the show a lot is like always having the backup plan, right? So in some cases, like let's say I can't get any torque on the tilted, I've tried the nose, I've tried sizing up, I've done all that kind of stuff. A lot of times, if I have a pterygoid, I'll just move anterior and just try again, right? But if none of that happens, like if I've got nothing in zone 2, of course, the topic of a zygo can come up, right? And I see a lot of cases where they do the rescue zygo, right? Like they just weren't able to get anything in the middle. They didn't exactly plan on it, but they said, you know what? There's some really good bone up there, and I really want to immediately load this case, and that's what they do. I think a lot of times that may not have been discussed before, the case was taken on, and maybe someone's gotten a zygo that was kind of a surprise zygo. But generally that tends to be the knee-jerk reaction. Like if someone can't make something happen in zone 2, you need to be prepared to place that inferior posterior zygo.
Yeah, 100%. And we're kind of starting our zygo journeys now, and it's from the people that have been doing this a lot. It's like they say like obviously it's more reflection, blah, 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 but compared to pterygoid, right, technique wise, it's a little more straightforward because you can visualize everything. That aside, even if you could have this in your tool belt, I just question, whenever I see cases like that, you'll see the classic post I see is, oh, didn't get enough torque on my posterior implants, but good thing I know how to pivot to zygo. And
Yeah.
I'm not here to try to, I don't know the situation every time, but the way that's brought up and the way that's written, on Instagram or whatever, just kind of irks me in a way because I'm like, well, I'm sure that's in the informed consent, somewhere these patients had a piece of paper, like they're good. I told them that zygos were a possibility, right? But did the patient actually really understand that this is the last resort option? Does the patient really understand that it's hard to pivot from a zygo, especially if it's a younger patient, I just think of, if I had to send, God forbid, my mom to go get FP3 and she was indicated for it, standard case, she just has soft bone, but she comes home with a zygo, I personally would be pissed,
Yeah.
because I know
Yeah,
So,
you know,
you know,
you know what you just got into. Yeah.
right, exactly. And so what's the difference between wearing a denture for 3 months and, just letting things heal, and then you uncover, and then there you go. The way I explained to my and this is, this, I know this is a bit of a tangent, but this is another kind of like thing that I'm really, all under the umbrella of being optimally invasive, right? Is are we giving our patients true informed consent? Where I really saw this, um, illustrated to me, it was actually one of my own experiences. I had thyroid cancer. Luckily, it's one of the best ones to get, papillary thyroid carcinoma. Thank God it was that one.
Yeah.
But in 2022, I had to get it shucked out, and I had a general surgeon that was specialized in endocrinology do the procedure for me. And during the consult, he discussed, hey, Sean, like he's a nice Southern dude, like spoke real slow like this, but he was very thorough. And he was like, Sean, like I know you're a nerd about this stuff. I know you've read about this already, like because we had talked, before. And
Yeah.
he's like, there's a good chance that when we're in there and there's tumor on the internal and recurrent laryngeal nerves, that I'm going to cause some damage to it. Now it's going to be paresthesia, unless I cut it completely. Like, but we have two choices here. One, I go in there, I try to get it as much as I can off, surgically. That will increase the chance of paresthesia and or even, possibly anesthesia, right? Or two, I leave a comfortable amount of that tumor on these nerves, and we can try to get the rest of it with, chemo, with radiation or
Right.
whatnot. How would you like me to proceed in that situation? And I was like, man, this is true consent.
Yeah.
I was
Yeah.
just like, Dr. Davis, thank you so much for yeah, I had read about it, but if it was the lay person, right, they wouldn't know, and man,
Yeah.
what a great thing for a doctor to explain to their patient. Hey, what would you rather go down, and so I chose the more conservative option. And so applying that to how I give consent, um, for borderline zygote cases, right? Like, let's just be very specific is, hey, Ms. Jones, like based on your scans, it looks like your bone density is really low. Like, there's a good chance that, we have enough bone, luckily, for conventional implants, for just normal 4 implants. I pull up a picture, I show them they're this long, even put up to my face, it's this long. If it's soft, like I said, it's just like a nail in the wall. If it sticks, then we can put a picture on it. If it doesn't stick, then we can, we have two choices. We can either, one, if you really, one, we can wear a denture for 3 months, let it heal and uncover you in 3 months, and you'll have a set of teeth that can attach to it just as long as it's healed. Or
Yeah.
two, if you really, really, really care about having fixed teeth the same day and walking out with fixed teeth, we can do that option, because I'm not placing zygotes currently. What I'll say is, if you really care about that option, I will refer you to one of my colleagues that can place zygomatic implants. That is something they could pivot to during the surgery, if that is something that is really valuable to you. How would you like to do
Mhm. Yeah. Yeah. That's good.
That's it? And
Yeah.
two,
That's really.
this does two things, right? One, it really involves the patient in their decision process, right? We're not telling the patient to tell us how to do the surgery. I'm not saying either one of these paths is right or wrong, but what does the patient value? You know,
Yeah.
we're involving the patient, we're informing them correctly because they know what a zygote is. They show them, hey, look, conventional implant is this long, zygomatic implant is this long. Zygomatic implant usually is, I like to save those for the end,
Right.
if one of these shorter ones fails, that's what is likely going to happen, So once they explain all of that, man, I haven't had a single patient yet tell me that they want a zygote.
Yeah. Yeah.
Um,
That's impressive. Yeah.
yeah,
And I think it's such a great example too, because like, when you're talking about someone who's already been wearing a denture for some amount of time, 3 more months is not a big deal. If they have another option down the road, like they'll probably just take the denture, I mean, just to save themselves that option. Like they don't have to get teeth yesterday, I think it's definitely different if, let's say, this is a person that still has all their teeth and they just got extreme perio and the bone is just mush and you take it all out, you try to get down a good clean bone, there's just nothing left and now it's time for a zygote. Well, yeah, that's a patient that, was trying to avoid having removable teeth and they might, you know, say, I can't go out of here in gums. Like, do what you got to do. Give me some teeth the same day. And you know what? No matter what happens, people can deal with the path that they chose, no matter what that means. Like, if they knew that that's what they were choosing to do, they're going to be a lot nicer and a lot less likely to come after you for something if they were well informed and they chose that path and they knew what the risks were.
Right.
So I think it's extremely important. Yeah.
Yeah, and in that situation, right, like they were involved in the decision-making process. So if they chose, you know what? Yeah, I would really like to get teeth, but I also don't want to use my last resort option, like
Yeah.
just like then that the pressure's off you during the surgery. You're not going to be doing crazy stuff on a 40-year-old, like place a 5 millimeter diameter implant on it. Like that's also, in my opinion, not being as optimally invasive, right? You're going to have to revise that. I'd rather place the 5 millimeter diameter implant later on.
Yeah.
It just puts so much pressure, takes so much pressure off you as a surgeon too, right? You're like, all right, it's an optimal position, a normal, 3.75, 4 millimeter diameter implant, whatever is your workhorse. The patient said they were okay with the denture. Sick. Let's move on. Denture for 3 months, graft everything else, soft tissue, do all the things that we're going to talk about to optimize them for uncovery. And then there you go.
Yeah.
They made a decision. They're cool with it. Or if they really want that zygote, you get the training to place it where you refer it.
Right. Yeah. No, I think that's great. I actually had kind of a recent personal experience with something like this. So I got, it was probably like 2 years ago. I got consulted for my nose. So like I have a deviated septum. It's like broken in different places and there's not a lot of cartilage there. I can't breathe at all. Like you can hear me like sniffling all the time. And like my outlet is completely closed when I try to breathe, especially when I'm working out and stuff. There's just no chance. And I got a consult about this a couple of years ago, and the plastic surgeon that talked to me, it was very all or nothing. The type of approach. It wasn't like, oh, we can just go in here and fix the deviated septum. It was like, no, if we're going to do anything, we have to do everything. We have to go in. We got to take some cartilage from your ear. We got to get some rib cartilage. We got to go through. We got to totally reconstruct your nose. We're going to have to straighten it, do all this stuff. It's going to be cosmetic, but it's also going to be functional. It's going to be great. And to me, like I kind of felt like a patient that was getting fit into an FP3 box that didn't need to be there. Like that's literally how I felt.
Yeah.
And the cost was actually pretty similar to like a fixed full arch. And I was like, yeah, I don't know if I like this approach. It made me very critical of my own approach. I was like, man, I really got to think about how I, talk about these things. And then most recently, I think it was about, a month ago, I'm out in Washington now, so I got to meet a new doctor or whatever. And the approach was totally different. They're like, look, you're a young guy. Your nose is fine. Owen Wilson made it just fine with his nose looking all fucked up. Like, don't worry about it, right? And he was like, "Look, he's like, look, this is what we're gonna do." And like, it was a much more conservative procedure. And he was like, "Look, worst thing that's gonna happen is nothing, right? Like, the worst thing that's gonna happen is no improvement at all. And then we can talk rhinoplasty or whatever, but I won't be the one doing it because I just think that's irresponsible. I don't. You got a long life to live, and there's a lot of things that can happen. There's a lot of morbidity associated with that. And you know what, like." At this point, I don't even know what he's going to try to do, even cost. I don't care. Like I'm going to go with this person because he talked me through the entire thing, gave me actual options,
Yeah.
And told me all these different paths and allowed me to choose it, and I think that's what being a real doctor is about. And not just being a full art salesman that can place screws. There's a big difference there. And I think the doctor is the one that gets to do this a lot longer, gets to have, a wealth of cases under their belt that ends up being really good at this because, they practice with integrity and they, like you said, they act like a doctor. So I think that's really important. I think engaging with your patients and treating them like people and treating them like, like treating them like something could go wrong and they need to know that, right? Like that's important. Now, granted, do I tell every patient that, if things go wrong, we might place a zygote and they might end up with a hole in their face? There's a more gentle way of
Absolutely.
doing that. You definitely don't want to scare people. These are people that have been finding reasons not to get something done for decades, right? They've been kicking this can down the road. So it's obviously a balance. The way that you talk about these things is important. But most people will gravitate towards a well-informed, or rather a well-informed surgeon that also makes them well-informed. And that's extremely important. And yeah, you can have all these different consents that talk about this and that. But like you said, like people don't really know what they're getting into. I mean, I know people don't read my post-op instructions because they ask me the questions that are right there in paper all the time. So like, they're of course they're not reading their consents. Of course not. They get them done in like 5 minutes. There's no way. I don't care who you are. You're not reading that.
No.
But yeah, all great points. I think, this all comes back to the expectations that we set and, learning how to, communicate our treatment plans effectively and also making sure that your team is well calibrated and understands those things. That isn't just trying to sell arches. It's really important and, these things matter a lot. And I think that, one of the most insidious things about full arch is that, you can be very successful ignoring all of these things, for a while, right? Like you can do these cases, you can drill 4 holes, put some screws in there, attach some teeth, and like patients will love you for like a little while. But it's not long before, reckless decision making, comes back around and shows you what that really does. And, it makes you question, like, did I really know what I got myself into,
Right.
Yeah, that's the seductive thing about full arch is it's very rewarding. Just what you can do in one day is extremely rewarding for everybody. But it's on that follow-up that really, defines, whether or not the right choices were made. And, it's just not fun getting in hot water. And inevitably, if you want to be a volume full arch person, like you need to know case selection, you need to know how to talk to your patients and set the right expectations. So I think your points, land really well with me.
Yeah, 100%. And kind of moving to our next point of like getting to regenerative dentistry, like, hey, like,
Yeah.
and being optimally invasive, setting patients up for success for long in the future is one of the things actually that I was scrolling through on my case study is like, hey, like I need to start tracking, the time at which patients need their first soft tissue revision or something additional. Right. Because that's something I haven't read. And and again, there's so much literature out there. If any listeners have heard of a paper that has looked at this, but like the average time that it, from initial surgery for full arch till when they need some soft tissue revision, I would love to see and read. But that's something that I'm looking at tracking too, is like, hey, like I mean, the theory is yes, short answer, yes, it's absolutely worth it to spend the time to do these things, especially if you already have, these things at your disposal. You're not having to go overboard and try to graph, being overly invasive for that.
Yeah.
But within reason, what are things that I can do easily? Yes, it'll take more time on the day of surgery, but it'll set them up for a longer amount of time.
Yeah, and it sets you up to not have as many revisions, right? Like that's another thing is like if
Yeah.
you spend half your time doing your own revisions, like you'll burn out pretty darn quickly. Like it is so important to manage your revision rate and do things right the first time because things are going to go wrong whether you do it right or not. But they're going to go wrong a lot more often if you don't do it right. So,
Yeah.
yeah, that's a great point. So yeah, let's talk more. Regenerative dentistry. Let's talk about just kind of some basics. So let's say let's say I'm a dentist that doesn't has been doing some full arch. I've done some all in four here and there. But I've really been kind of irrespective of soft tissue. I've read zero boneless concepts. I know that keratinized gingiva is important, but I don't know a whole lot about, what I really need to do to make sure that my implants are going to be protected. And I don't know anything about hard tissue. So like, where do I kind of start? What are some like starter things that I should start practicing here and there, to kind of warm myself into that, augmentation world?
Yeah, absolutely. And I'll be if I can plug something here, but no, I
Oh,
really, I wrote this article actually. Just it's the whole point of the article is just learning. It's talking about the high yield skills to have in dental implantology, and that has nothing to do with just slinging the titanium, right? And so I wrote this article about a year ago, I think. Shout out Steve Warhol for connecting me to the editor for Implant Practice US. For giving me this opportunity. But yeah, I essentially wrote this article for a younger me who was like, man, like what all do I need to learn to be not just good, but excellent at dental implantology. And it just outlines all these high yield skills that we can have, and we can share the link, in the show notes or whatever.
yeah, I took a note. Yeah.
But essentially, yeah, it just talks, it talks about hard tissue augmentation, and we'll talk about the varying levels of augmentation. The fundamental surgical skills that are associated with that. So periosteal release, buccolingual flap advancement. And I think the more I've learned about hard tissue, the more I've learned that it's actually a soft tissue game. And I don't mean just
Yeah.
FPG and CTG, but it's learning how to mobilize and manipulate the mucosa, the gingiva, and all that. And yeah, fundamental suturing and membrane stabilization skills. Then you have soft tissue augmentation. I think is another huge area that that can give you a high yield area for success. Just starting with the humble FGG, and the different types of FGGs, that harvest methods. Um, so FGG with applique position flap. You have connective tissue graft and the different ways that you can harvest that. And then you have your pedicle flaps, like your pedicle, or your even on the mandible, anything that's connected that stays connected, lateral rotated pedicle flap graft, all the way up to your buccal flap pad, right?
Yeah.
Kind of like the last kind of big area is just learning, especially with all on four, we're working, surfing the sinus all the time, be really
Yeah.
close to that. Even taking out teeth close to the sinus, being comfortable in the sinus, not just for the sake of doing a lateral sinus window, a lateral sinus graft, but being able to do
Yeah.
one to, say, retrieve an implant, or
Oh, yeah.
to, say you have some pathology in there, doing transsinus, like just being comfortable in that area, which many dentists are, very uncomfortable in.
Yeah.
Those are the areas that I was like, man, like these I really need to get good at, and that will take me, not all the way, but man, it'll boost me really, really quick, exponentially. Yeah.
Yeah. Yeah. I definitely think it's important to just know how to do a Caldwell Luke, right? Because like the sinus is an abyss of uncertainty for a while. I think most people they learn it because they have to do it, in the moment. It's not something you can exactly practice, but you have to get familiar with the sinus. Like you're gonna drop stuff in there, it's gonna happen, teeth are gonna go in there. So I definitely think that's important. So yeah, talk to me about okay, I'm going into my case. I just listened to the Shaman episode on the Fix podcast, and I want to try an FTG. What's a good harvest site? Maybe I'm looking at my number 23 implant, and it's got a thin band of keratinized tissue. What should I do about this before I close?
Yeah. Essentially, so it also depends too, right? If you're doing this surgery, uh, if you're placing implants, we call that stage one surgery. Like I would, have your full thickness flaps already open. You've done your all on four. I would prefer using a CTG in that case. Yes, you can use FGG secured to bone. That's fine. And honestly, this all has to do with how thick your donor site can be. If you have enough thick enough tissue, I prefer to just take a that's connected tissue graft. Say if you have 4 millimeters total palate, you can take a 2 millimeter thick CTG and still have at least 1.5 millimeters of palate, so it doesn't just necrose. And for that, since you have the full thickness palate open, I would just take the more the deep half of it versus the superficial half.
Of course.
Take that out, and we'll talk about the difference between that too. Or the nuance will be in the article as well. But yeah, it's very simple. You're trimming the palate anyway, likely if it's a thick palate, to for the reasons that we discussed before, and you just tack it to the buccal or lingual.
How do I
Another
kind of can you walk me through that? Like the
yeah,
tacking?
so I just need like it really is just it is the easiest time. It's the easiest way to do. You don't have to do any kind of fancy tunnels. You don't have to do any fancy like anything. It's just a simple interrotted suture essentially, where you bite the flap. Say it's so I prioritize the lingual flap because it's harder for me to go back and do a lingual applique position flap versus on the buccal. So now I actually prefer, if I only have enough to graft, one side, I prefer the lingual side, to be honest. And I cheat more of the keratinized tissue, and sometimes I'll even cut all of it and just give it to the lingual, because on the bucking, I'm confident that I can fix it later on. I'd
Really?
much it's easier to work when you don't have a huge lingual artery, running
Yeah.
the ridge, right? So anyways, you essentially just take your flap and you purchase it with your needle, and then the next purchase will be your connective tissue. You'll loop it around, and then you go connective tissue out the flap, and you tie it. It's a simple interrupted knot. And depending on the length of it, you just do, obviously you don't want to tie it too tight, because you don't want to squeeze the living hell out of it. You want to secure it so that doesn't really move. I like to secure it at least like a millimeter away from the flat margin, because you want to leave some room for you to actually get,
Closure.
around and not bunch up. And sometimes especially if you're suturing around an abutment, you actually want to go a little bit further away from the flat margin, because what you don't want to do is have that CTG just bunch up around I use my cup here, but bunch up around the
Verts around it. Yeah.
There's no blood flow to that.
What's it going to adhere to?
Yeah, you probably have enough from the overlying flat, but you want to kind of optimize the situation, right? Another way you can do it, right, is just like that poncho technique that Dr. Toe showed at Orca. Calamari technique, poncho technique. You just kind of cut a hole into the CTG depending on how wide it is, right? And for me to make that decision is just how wide of a graft I can get, right? We have long, we have wide. If you can get a really wide one or wide enough, adequately wide, connective tissue graft to do that technique, then do a poncho.
Maybe I misspoke earlier. So when she did that technique, I said it was an FTG, that she had just taken everything, the epithelium and the connective tissue, and then done the poncho. Was that actually a CTG? Did I misspeak on that?
I can't remember exactly what she did, but technically you can do either or. You can do either or. Yeah, and actually that's what the calamari technique is. You're taking it's actually I saw this from Dr. Springer. If you guys don't follow him, he does great work. Him and Dr. Grogger. There's a specific ring punch, like tissue punch, that you can use. It essentially cuts like a O-ring, like the piece of calamari from the region usually, and then you can just put it around your abutment and you secure it that way. But usually, like for full arch, right? We're talking full arch application. At the time of surgery, the most straightforward thing for me to do in that situation is just good old CTG.
Yeah. Okay. Cool. Yeah, that's fantastic. And you're going to harvest that from tuberosity, from palatal tissue, wherever it's going to be, and you're going to get a decent amount of thickness. Is there a general rule about the width versus the length of that harvested CTG, as far as like, if you're going to go this long, you have to go this wide to have proper vascularity? Is there any rule that people need to kind of keep in mind there, or no?
No, that's a really good question, because you do have to keep that in mind for pedicled flaps.
You're trying to maintain okay, that makes sense.
Exactly.
Okay.
And there's a rule for that. I'll give the reader some homework. You can't just give out all the answers, right?
Of course.
Go look that up and email me the answers. There is a requirement to maintain blood supply, right? It's the joke in surgery, right? Like the answer is always, well, blood supply, right? It's a very important thing, right? But for non-pedicle flaps, it doesn't matter. Yeah.
Okay.
You just want to make sure that it's thick enough and wide enough, taking into account some kind of contraction and knowing that it will shrink a little bit, especially with FGGs. And there's a whole nuance into that too. I don't think we have enough time to discuss that, but just know that, we have to take a little bit larger, just overgraft it a little bit, right?
Okay.
But there's no requirement as far as blood supply goes.